Excellent. Good morning, ladies and gentlemen. Honorable Ministers, our esteemed panel, good morning. So my name is Ibrahim Abubakar. I'm a current chair of the WHO Strategic and Technical Advisory Group on TB and also Professor of Infectious Diseases at University College London. And I'll be leading discussions this morning. We have a highly esteemed panel with experts, honorable ministers, and senior policymakers from low-incidence countries. And I'm absolutely certain that we're going to have an excellent session and some really good deliberations that should inform the future of TB elimination globally. So I'll start by giving a general structure of the discussions and sessions so that people know what to expect. We will start with introductions of our esteemed panel, and then I'll give a very brief overview of the issues and objectives of the session, and then we'll take it in turn in the order that we are seated to respond to specific questions that I will pose to our esteemed panel members. We'll then conclude with the last part of the session, where individuals can ask additional questions, and if there are no questions from the floor, I will be putting additional questions to the panel members. All of the discussions will center around TB elimination. So if I might just kick off with a few words. So this session has been designed largely to discuss the challenges and opportunities that are centered around TB elimination. And you know that this has been a topic that has been on the global agenda for a while now. Countries like the United States through the US CDC and the Institute of Medicine have had for a few decades now formulated documents and policies thinking through how do we do elimination. This has culminated more recently in the WHO together with the European Respiratory Society publishing a document a few years ago, and you will see it in this leaflet which are available at the back of the room. The policy document is called Towards TB Elimination in Low-Incidence Countries, and that strategy articulates the global approach that we should take. It has a number of 8 priority action areas that we'll be covering this morning. So there will be discussion on most of these top 10 action areas. And they range from political commitment, which is absolutely critical, and we're lucky to have government ministers here who would tell us how we get governments to commit to TB elimination in this very difficult era of low budgets. We'll then move on to TB in risk groups and vulnerable groups. As you're aware, TB, as the incidence of TB declines, it increasingly focuses on particular risk groups, and these differ in different countries. And so we get insight from a number of senior government officials on what we do and their experiences in tackling TB. We'll then conclude the session with input from agencies that have been involved in supporting higher burden countries. We know that although we have geographical borders between countries, TB can travel with people as we move across the planet. And one inevitable nature of mankind, which is been around with as long as man has existed, migration. People will always move. Therefore, we would have to deal with how TB spreads between countries and how we support those countries to tackle TB before people arrive in low-incidence countries. So without wasting any more time, it's my pleasure to just briefly go around and introduce our esteemed panel. So just to my left, we have the Honorable Minister of Health for Slovakia, Mr. Tomáš Drucker. Pleasure to have you here. We have the Acting Vice Minister for Public Health for Cuba, Dr. Duran. We have the Director General for Health Authority for Denmark, Mr. Søren Brostrøm. And we have the Deputy Chief Public Health Officer and Vice President of Infectious Disease Prevention and Control Branch for the Public Health Agency of Canada, Mr. Dr. Njoo. From Sweden, we have the DG, the Director General of the Public Health Agency of Sweden, Johan Karlsson. And we have the Director of the European Centers for Disease Control, Andrea Ammann. And then we have the Principal Sector Specialist for Health from the Department of Foreign Affairs and Trade, DFAT in Australia, Stephanie Williams. And finally, we have Susan Maloney, Chief Global TB Branch, USCDC. Thank you. So I will now kick off the discussions in the session. And the first aspect of our discussion centers around political commitment. We all recognize that a strong political will is critical to TB control. And in this regard, it's really a pleasure to have you, Honorable Minister Tomáš Drucker, in this discussion. And it shows that the government of Slovakia is committed to TB elimination. Just your presence, I think, proves that. So as countries reach low incidence status, TB becomes less visible, with the exception of marginalized groups and specific subsets of the population that are generally deprived. It's also the case that awareness falls. People such as healthcare workers who should be making the diagnosis, general public who should know about TB, as well as policymakers, become less aware of TB. How do we keep senior government officials and leadership of a country in the context of this very low incidence to move towards elimination? How do we get that political commitment?
Thank you very much. Still good morning, ladies and gentlemen. As we discussed last year, TB is one of the main causes of death from communicable diseases and remains an important global problem. We appreciate that TB is rightly highly prioritized within the WHO, together with HIV, malaria, and hepatitis under the upcoming WHO General Program of Work. TB is not only a threat to the public health, but it also has a far-reaching social, economic, political, and security threats that have significant cross-links in terms of comorbidity with other conditions, especially with HIV/AIDS. Although TB mainly affects vulnerable population groups, the Mycobacterium tuberculosis transmission does not respect any borders and can virtually involve anybody living in high, middle, and low-income countries. The occurrence of these generates protracted human suffering and catastrophic costs to patients, their families, as well as to the society as a whole. Thus, sustainable and effective measures are needed to ensure quality-based prevention, diagnosis, and treatment for TB and latent TB infection. Implementing them as integral part of both the human rights of the affected individuals and the public health prerequisites to control and eliminate TB while preventing further development of multi-drug-resistant TB and extensively drug-resistant TB. Since tuberculosis is still the most serious social illness, it's necessary to pay special attention to certain groups of population who have significantly increased risk of developing tuberculosis for various reasons, mainly poor socio-economic conditions. The classical risk groups of the population continue to include socially excluded, alcoholics, homeless people, and older. New risk groups have been added to them in recent years. New cases of HIV infections, migrants, and people infected with multi-resistant tuberculosis strains have become new risk groups with a strong reflection on epidemiological indicators worldwide. In Slovakia, one more all new group, and it's a Roma, requires special focus. The health of disadvantaged Roma communities is a big challenge that calls for a smart response to their specific health, social, and education needs. One of the most effective ways to improve the care of this ethnic group is the introduction of health mediators, Roma assistants who, for first contact between health workers, such as doctors, nurses, and healthcare assistants, and individuals in Roma communities. Smarter communication without linguistic and cultural barriers can play a key role. Health mediators who work in cooperation with healthcare providers and municipal governments are the main pillars of the national-wide multi-sector project, which is called Healthy Communities. It's run by the Platform for Support and of Health Disadvantaged Groups. The main goal is to improve the Roma community's health by increasing levels of education and employment. The long-term vision is to implement programs and measures with a major impact on reducing health inequalities. It aims at achieving significant improvements in access to health services, information, and contributing into the increasing health literacy and individual responsibility for their health, and contributing into the integration of the excluded groups of the population into society. Our National Institute for Tuberculosis, Lung Disease and Thoracic Surgery in Višnahagi has implemented the TB educational program for training of health mediators from Roma communities, and it's a cooperation effort of the Ministerial Health National Institute in cooperation with other institutional stakeholders, GP specialists, and WHO office in Slovakia. The activity successfully prepares field workers from marginalized groups from a disadvantaged environment to promote the health of their communities. These field workers provide cooperative contracting for basic medical examination as well as follow-up on the continued treatment of patients with tuberculosis under outpatient conditions. Educational activity trains mediators how to remove the prevailing prejudices and concerns of the Roma about prevention and vaccination, while stressing the importance of length of TB drug therapy after discharging from hospital in order to prevent the emergence of resistant tuberculosis strains due to untimely termination of treatment. In conclusion, Slovak Republic would like to highlight the following 3 points. First, TB is neither highly virulent nor easily transmitted and is treated. Therefore, efforts should be made to promptly detect and treat. Provision of adequate treatment is essential to break the chain of transmission within the community. Second, diagnosis. It is not always easy to perform in all settings and circumstances, particularly in centers hosting large number of high-risk individuals, including socially disadvantaged ethnic groups, migrants and refugees. Therefore, political commitment at national level is immediately required to address this important gap in the cascade of care. And third, suboptimal medical management of TB and/or inadequate follow-up of individuals or patients will hamper TB control and elimination efforts. Therefore, education of healthcare workers, engagement of risk groups, and identification of reference centers should be a priority to improve the public health outcomes and to reduce the inefficiencies of healthcare-related financial resources. Finally, I would like to reiterate my proposal stated during Regional Committee in Budapest. On the basis of Slovak Institute for Tuberculosis, Lung Disease and Thoracic Surgery in Višnahagi, to establish WHO Collaboration Center, which will serve the need of European region. Thank you very much for all of your attention. Thank you.
Thank you very much, Honourable Minister. That was superb and clearly shows political commitment. Looking at my colleague, Alan Solowik across in the audience, so we used to be both program managers. I was program manager for England, and I wish I had as committed a minister as you. Thank you. Excellent. So I'll move on now, still on the subject of political commitment. Cuba is a country that has exemplified to the world that it is possible to maximally use modest resources and achieve incredible amounts of healthcare, and TB is no exception. So we're lucky and delighted here to have the Acting Vice Minister for Public Health, Dr. Duran. I'll be very interested to hear what you think are the success factors in Cuba in advancing the TB control agenda within the context of universal health coverage, and how you manage to maintain commitment and strengthen efforts towards elimination within Cuba so that other countries can learn. Thank you. And the response will be in Spanish, so if you can switch on your device. Thank you.
Primero, buenos días y me disculpan los traductores y los panelistas por hablar en español. Realmente, primero agradecer la posibilidad que nos ha dado la Federación Rusa de la Organización Mundial de la Salud de efectuar este intercambio muy provechoso. Segundo, y ya entrando en el tema de la pregunta que me ha hecho, en Cuba la tuberculosis era una de las principales causas de mortalidad que nosotros teníamos en la década del 60. Momento en que se implanta por primera vez un programa nacional de control de la tuberculosis que ha ido permitiendo una reducción tanto de la morbilidad como de la mortalidad, que nos dio la posibilidad de que en el año 2016 termináramos con una tasa de 5,6 por 100.000 habitantes de morbilidad, de incidencia, y una tasa de mortalidad de 0,3 por 100.000 habitantes. ¿Cuáles han sido los factores de éxito? Como bien usted me preguntaba. Primero, el compromiso político con el Sistema Nacional de Salud y, por lo tanto, para el control de la tuberculosis, con un apoyo gubernamental y un presupuesto anual destinado al Sistema Nacional de Salud que representa el 28% del presupuesto del Estado y más del 9% del Producto Interno Bruto. En segundo lugar, como también se conoce, la cobertura nacional del sistema de salud con un enfoque preventivo basado fundamentalmente en la atención primaria de salud, un acceso universal y un acceso gratuito tanto a la atención como a los estudios, como a los ingresos, como a los tratamientos diferentes que se realicen en nuestro país. Es importante para el Programa Nacional de Control de la Tuberculosis, que es desde la atención primaria, sepan nada más que nosotros tenemos en cualquier lugar de nuestro país, digamos lo mismo en una zona urbana, que en una zona rural, que en una zona montañosa, un médico y una enfermera de la familia que se ocupan de la salud de aproximadamente 120 familias. Eso nos da una cobertura de un 100% de la población con médicos de la familia que garantiza los tratamientos más complejos y los medicamentos más avanzados, pero también garantiza el estudio, digamos, de los sintomáticos respiratorios más 21 y garantiza el tratamiento controlado del 100% de los pacientes que estén diagnosticados. El 100% de nuestros niños ya cuando salen de la maternidad, después del parto, salen vacunados con el BCG, y hay que decir que el 99, a veces 0,5% de nuestros partos se realizan en instituciones hospitalarias. Por lo tanto, se garantiza la vacunación. El tratamiento gratuito con drogas de primera y segunda línea en ambas fases, estrictamente, como yo dije ahorita, controlado y supervisado por el equipo de salud de la atención primaria de salud, una red de laboratorios diagnósticos descentralizados en todo el país, en 450 unidades de salud, desde el nivel primario, municipal, provincial y un laboratorio nacional de referencia, que es a su vez centro colaborador de la Organización Panamericana de la Salud y la Organización Mundial de la Salud para la eliminación de la tuberculosis, que se encuentra, como conocen algunas de los presentes, en el Instituto de Medicina Tropical de Duran, y el establecimiento y fortalecimiento de los sistemas digitales para poder recopilar, almacenar y analizar todas las variables de información que permitan realizar acciones integradas, estratificadas y oportunas. El Programa Nacional de Control de la Tuberculosis, que, como dije, está basado en la atención primaria de salud, tiene entre una de sus características la intersectorialidad, en el cual en la estrategia de eliminación forma parte de la agencia de otros sectores, digamos Ministerio de Cultura, Ministerio de Educación, Ministerio de Educación Superior, Ministerio de Agricultura y otros sectores del país en las actividades de prevención y control. La incorporación de la sociedad civil, muy importante, en las acciones de pesquisa en los grupos vulnerables a la tuberculosis. La movilización social con participación comunitaria en las acciones de promoción, prevención y control de la tuberculosis. Es importante la legislación que existe en nuestro país de una cobertura de seguridad social que garantiza que la persona enferma, si es trabajador, durante todo el tiempo, los meses o los años que esté en tratamiento, se le garantiza el 100% de su salario. y una dieta hiperproteica subsidiada a los pacientes durante todo el tratamiento que garantiza su alimentación. Ahora, ¿cómo nosotros podemos mantener nuestro compromiso y fortalecer más las acciones? En primer lugar, para nosotros es sumamente importante el mantenimiento del compromiso político que se mantiene en nuestro país, la cobertura nacional del sistema de salud, lo que yo dije de la seguridad social, el Programa Nacional de Control de Tuberculosis incorporado a todo el Sistema Nacional de Salud, el Plan Estratégico Nacional por 2015 del Programa de Tuberculosis y VIH, la identificación, el estudio y el seguimiento de las poblaciones vulnerables que se mantienen especializadas con una pesquisa anual, la incorporación de la sociedad civil, el estudio de los casos de tuberculosis y sus contactos, el algoritmo diagnóstico de la infección latente de tuberculosis y su tratamiento, las comisiones provinciales de tuberculosis, la red nacional de laboratorios, que estamos en un proceso de fortalecimiento con nuevas técnicas rápidas de diagnóstico, los recursos económicos para el control de la tuberculosis totalmente planificados por el Estado y la realización de investigaciones operacionales de líneas priorizadas. Ustedes dirán, bueno, en estos momentos, después del reforzamiento de la elaboración del Plan Estratégico Nacional de Tuberculosis en el año 2015, reforzado con nuestras principales prioridades, ¿dónde diríamos que se nos concentran los problemas? Primero, la atención integrada para todas las personas afectadas por la tuberculosis y la infección por el VIH, o sea, la coinfección, con un énfasis especial en lograr que las personas infectadas por el VIH no mueran a causa de la tuberculosis, mediante la búsqueda intensiva de tuberculosis entre estas personas, la existencia de un protocolo para la prevención de la coinfección y la reducción de la carga de VIH entre los pacientes de tuberculosis. El control de la tuberculosis en los privados de libertad y el control de la tuberculosis en extranjeros, sea residentes procedentes de países de mediana y alta carga de tuberculosis, y para los colaboradores cubanos que prestan servicio precisamente en estos países. Y decimos esto porque, sobre todo en la coinfección, nosotros en el año 2016 terminamos que el 12% de los casos nuevos fue precisamente de coinfección. Por lo tanto, es uno de los grupos que tenemos pensado y que además se garantiza el tratamiento, la profilaxis con isoniazida 6 meses, independientemente de que no sea positivo. Realmente en eso estamos trabajando y creo que nos va a permitir lograr la eliminación, las metas propuestas por la Organización Mundial de la Salud y seguir reforzando cada vez más. Muchas gracias.
Thank you very much for that comprehensive intervention and beautifully illustrating why universal health coverage is important. I think we need to get people primary care, and then we need to get TB care within the context of universal health coverage. So I'd like to move us on to the next question. We've heard from both speakers that as the incidence of TB declines, it becomes increasingly focused on particular vulnerable and risk groups. So in fact, within the context of this increasing focus in risk groups and vulnerable groups, and the fact that we require universal coverage for everyone, I'd like to invite Dr. Søren Brostrøm from Denmark to tell us how Denmark is planning to ensure they're directing their efforts towards these hard-to-reach groups.
Thank you very much, Professor Abubakar, for the invitation to this panel and the opportunity to share our experiences in Denmark, and also thank you very much to the WHO and to the government of the Russian Federation for organizing this very important conference. So regarding the situation in Denmark, I first have to stress that I will focus mainly on the situation in the country of Denmark and not in the whole kingdom of Denmark. The Kingdom of Denmark also includes 2 independent jurisdictions in the North Atlantic, the Faroe Islands and Greenland. You perhaps know Greenland from the map, the largest island in the world, covered in ice. Very few people, a lot of ice bears. It has a population of 55,000, and Greenland has a special challenge as regards to tuberculosis, with an incidence rate in the recent years between 100 and 200 cases per 100,000. So that's a special challenge in Greenland. Greenland has an independent government and also an independent healthcare system. I'm happy to answer any questions regarding that, but I'm going to focus on the country of Denmark, which is low incidence. So in Denmark, with a population of 5.6 million, we have an incidence rate of 6 per 100,000. This is fairly satisfying and certainly a low incidence country. The rate of decline in our incidence rate in recent years has been 2%. That is not satisfying, and it certainly concerns me that we might not reach the target of TB elimination by 2035 with that slow rate of decline. So that is not satisfying. On the positive side, we're looking at TB control in my country. We have a strong healthcare system with universal health coverage. We have also managed to centralize and specialize TB treatment to a very large extent. We are controlling that from the government, and I can confidently say that all across the country, diagnosis and treatment is of a very high level and high quality, and adherence to treatment is also very high. We have very few cases of multi-drug resistant TB, and almost exclusively in non-native population. We have also centralized and specialized laboratory diagnostics, one place in the country, and we have a laboratory confirmation of all cases in a reference laboratory. So that's all on the positive side. Going back to what is not so satisfying and what is our challenges, is that our rate of decline in the incidence rate is not satisfying at 2%, and it's not comparable to our neighboring countries. In a just recently published benchmark comparing Denmark, Finland and Sweden, we can see that the rate of decline in Sweden and Finland is much more rapid than it is in Denmark. It's around 6 to 7% in recent years in Finland and Sweden, and only 2% in Denmark. So obviously there's room for improvement in Denmark as regards to TB control. And also comparing to Sweden and Finland, we can see that we are probably not good enough in Denmark as it comes to early detection, and especially when it comes to contact tracing. Looking at the native population in Denmark, we are still seeing active transmission in vulnerable and hard-to-reach groups, mainly men with a history of homelessness, substance abuse, poor living conditions, etc. We have a higher rate of active transmission and a much, much higher rate of clustering in these groups of native Danish people as compared to Sweden and Finland. And I think comparing to Sweden and Finland, it's even more impressive looking at the results of our Swedish brothers, where they have a much higher immigration and a much higher case rate among immigrants, because they have a higher immigrant population than we have, to see that they are achieving a much, much better case control in Sweden. We have worked, and we know what will work, and you can see on the slide on the left side a mobile clinic that has been employed in the capital city of Copenhagen, which also has the large clustering and case rate, where they will go actively to these vulnerable groups with a focus on early detection and diagnosis, and also with a focus on contact tracing and treatment. I think we need to have, in my country, larger political attention to this, which can be challenging in a country with low incidence, to have that political attention to this vulnerable group, and we need to have a much more sustained effort of outreach programs like this mobile clinic that you see here, not only in the capital city of Copenhagen, but also across the country. We have recently, from the Danish Health Authority, which I'm the Director General of, we have recently published national guidelines on the care for TB, including contact tracing. So we have managed to oblige local regions who are running the hospitals to do the contact tracing. So the rules are there. We need to have more political attention, and we certainly need more effort. So that's sort of my introduction as regards to the situation in Denmark. Thank you.
Thank you very much. I always like excellent summaries of TB challenges in particularly vulnerable groups, because for me it is the conscience of society whether we are able to actually target and put additional investments in this particular group. And your input is even more interesting with the healthy Scandinavian positive rivalry. So moving on, along the same lines of vulnerable groups and targeting the needs of those priority groups in society that we should focus on in low-incidence countries, I'd like to ask Dr. Howard Njoo from the Public Health Agency in Canada to tell us how Canada is ensuring access to high-quality TB care to these vulnerable groups. Howard?
Thank you very much for the introduction. And first of all, I would like to thank both the World Health Organization as well as the government of the Russian Federation for organizing this very important meeting and for inviting me to be part of this panel. I do want to say that our Minister of Health for Canada, the Honourable Jeanette Petitpas-Taylor, regrets that she wasn't able to come to Moscow for this important meeting, but I am pleased to be here with you today and to represent the Minister of Health at this important event. So in response to the question, first of all, let me describe for you, for all of you, but I think it's similar to Denmark and other countries, that we're quite proud in Canada that a key aspect in terms of TB prevention and control is the fact that we have what we call a publicly funded healthcare system, commonly known by Canadians as Medicare. And this universal healthcare coverage is a key feature of our system, in which really it extends to all aspects of hospital and physician-related services for TB prevention, treatment, and care. However, compared to Denmark and other countries, a bit of a challenge in Canada is that it's a decentralized model, and therefore the actual delivery responsibility for delivery of these services falls to each of our 13 provinces and territories. But under a piece of federal legislation known as the Canada Health Act, we do ensure that all eligible residents of our provinces and territories have reasonable access to medically necessary hospital and physician services on a prepaid basis without incurring out-of-pocket expenses for the patient. As well, even for recently arrived immigrants and refugees who do not yet meet the residency requirements of any of the provinces and territories, the federal government steps in with our so-called interim federal health plan and also ensures that these services are provided. So technically and theoretically, there are no barriers in terms of accessibility to healthcare services for TB prevention control in Canada. But we do know, of course, that TB detection and treatment gaps do exist, particularly for certain vulnerable groups. And before I get into that, I'd like to describe a little bit about the epidemiology of TB Canada, which, similar to Denmark and many of the other countries on this panel, is one of the lowest in the world. So our TB incidence rate overall in Canada for 2015, the last year for which we have data, was 4.6 per 100,000. And that represents about 1,639 cases. However, over time, we have recognized in Canada that two main subpopulations continue to be disproportionately affected by tuberculosis. Specifically, our Indigenous peoples and also foreign-born individuals who come from TB-endemic countries. So in 2015, our foreign-born individuals make up about 22% of the population, actually accounted for 71% of all of our active TB cases, and our Indigenous peoples, who represent about 5% of the population, accounted for 17% of cases. If you look at a pure incidence rate for Canada overall, it's 4.6, but for our Indigenous peoples, it's 17.1 per 100,000. And if you look at a specific group that lives in the far north, our Inuit, the rate was 166.2 per 100,000. That's more than 270 times higher than the rate for Canadians who are born in Canada but non-Indigenous. And this certainly, I think from our perspective, is totally unacceptable. So why are these two groups experiencing TB at rates so much higher than the Canadian-born non-Indigenous population? Is it a question of access, or are there other factors at play? I think with many other countries who have low incidence rates, we recognize that if the rates continue to decline in Canada, unfortunately not, they remain steady, the overall level of, I would say, physician and also other frontline healthcare providers experience with the disease will also decline. And therefore, we recognize that a critical part of what we need to do moving forward is to continue to ensure that there's education for the new graduates coming out of the schools, but also continuing educations for those already in practice, so that they remain informed and up to date with the best current practices for TB prevention and control. We also recognize that agent and host factors play a role, but so do environmental factors, not the least of which are the socioeconomic determinants such as income, housing, and food security. In fact, as I was mentioning, for Inuit who live up north, 40% of them live in what we consider overcrowded housing situation. As well, we also recognize, particularly among our Indigenous peoples, that there's a deep-rooted distrust in the mainstream healthcare system, and there's a long history for that. We recognize that there were mistakes in the past, and we need to move forward and do better. But that's something we need to also acknowledge as we move forward. And to a lesser extent, I think there's also a distrust of the medical care system and how to access it for other vulnerable groups, such as homeless people, individual substance abuse issues, and also other stigmatizing conditions. So therefore, when it comes to prevention and control, we recognize that one size doesn't fit all. And we need to have tailored approaches to deal with our two main subpopulations so that we can really move towards TB elimination. So for the foreign board, what we're looking at are screening programs in place to combat TB prior to, as well as following arrival in Canada. Currently, all permanent residency applicants and longer-term visitors must undergo what we call an immigration medical examination, which includes a chest x-ray. And applicants found with active pulmonary TB are inadmissible until they can demonstrate they have successfully completed treatment. Applicants with an abnormal chest x-ray but don't have active TB, but certainly suggestive of inactive pulmonary TB, are referred to report for post-landing medical surveillance with the provincial and territorial authorities when they arrive. However, for the vast majority of immigrants, there are no routine post-arrival screening programs, but there are primary care guidelines in place for targeted screening programs organized by schools and other public institutions. So here's the key point in moving forward for us. As the world moves towards TB elimination, there's a growing recognition in Canada among the TB experts that more can be done to reduce the burden of TB among the foreign-born. And to this end, we are now actively looking at more effective approaches, more proactive approaches to address latent TB infection screening at critical points in the migration pathway. We also need to step up our efforts to identify and treat individuals with latent TB infection who are already living in Canada. So currently, Canada lacks a programmatic and systematic approach to latent TB infection screening and treatment that could better inform public health action across the country. Systematic screening for latent TB infection in at-risk populations, followed by the offering of treatment when appropriate, is a critical component, as we all know, of the WHO's framework for TB elimination in low-incidence countries. And so as one of those low-incidence countries, certainly Canada can do more, and we hope to be among the leaders in moving forward in this direction. So with regard to our Indigenous populations, I can personally attest to the commitment by the Government of Canada at the highest levels. In fact, our Prime Minister, the Honourable Justin Trudeau, has made it abundantly clear that no relationship is more important to Canada than the relationship with our Indigenous peoples. So in this context of reconciliation between Indigenous and non-Indigenous Canadians, we're seeing new, innovative partnerships being forged. They're dedicated to closing the gap in health outcomes between Indigenous and non-Indigenous communities. And one such partnership, which has recently been established, is the Inuit Crown Partnership Committee. And through this bilateral arrangement, federal cabinet ministers and Inuit leaders are working towards sharing best practices, shared priorities, and eventually, hopefully, TB elimination in the North. So in closing, we recognize the vision For TB Elimination Canada will take time and effort and ongoing engagement with multiple actors. No one entity can do it alone. So governments, communities, civil society, and healthcare providers all have a role to play in this collaborative effort. And as we move forward, there's much that we can share with many countries around the world, but also that we as Canadians can learn from the experiences in other countries. And certainly over the past day and today, I and I think the other Canadians who are here have gained valuable insights, which I certainly will take back to my Minister of Health, as well as sharing with other groups and individuals who are addressing TB Canada, so that we can eventually recognize and realize the goal of TB elimination in Canada. Thank you very much.
Thank you. So, strong parallels with the Danish example we had, in the many common areas of challenges and opportunities for control. I'm particularly delighted to hear about the interventions in your indigenous populations and strengthening your activity in that area, as well as on latent TB, because as we move towards elimination, that's where we must be going. Particular risk groups that are common to Canada and to many northern European countries are migrants. In many of these settings, the vast majority of TB cases are in people who are born in other countries, not in the country of interest. This challenge is an important one because it links back to the global control of TB, but it also presents opportunities locally to make a difference. So what I'm keen to do is to move on to our Swedish panel member and to ask Mr. Johan Carlson, Director General of the Public Health Agency of Sweden, to tell us the ways in which Sweden provides quality TB care for migrants, as well as how to respond to the holistic needs of migrants beyond TB care. Thank you.
Thank you very much, and also like to thank you for arranging this interesting seminar. Søren, my Danish colleague, said a lot about Sweden, and usually we beat them in football, but also in TB, I would say. We have a very special situation, actually. We had, it's needless to say that the health coverage is universal, of course, as in most European countries. But we also have a very decentralized system. There is no health system run by the government. Everything is run by local communities. So we are very much dependent on their efforts. We've had for many, many years, since after the Second World War, a comprehensive tuberculosis program, big efforts to be put in. Sweden used to be what today we regard as a high incidence country after the war. But we've been working hard, and we're actually done in the Swedish-born population. We're down to below one patient per 100,000 inhabitants, which is very low level. We had last year 90 patients only coming with tuberculosis. But we have the situation, the migrant situation. So of the 800 plus cases in 2016, 750 were migrants, which puts us in a very special situation when it comes to tuberculosis. I mean, I would say put almost all efforts into the situation. So we have a program linking the migrant program into the old, well-equipped program we've had for many years. That is, we are offering migrants or asylum seekers a screening program, screening for active and latent tuberculosis. They're invited to a health examination and health talk, a more comprehensive talk. We talk about their health problems, not only communicable diseases, to make them understand that it's important not only to have the testing when they arrive, but also to link into the Swedish system very much. Because as you all know, testing on arrival is one thing, but also the follow-up to make people aware of the disease is just as important. And I say it's a voluntary screening. We always work with voluntary systems in the vaccination system, in health screenings. People usually come when they're offered something. That's their experience. The problem we see is that the local community not always are able to provide this in a timely manner. That's the main problem. But by and large, it's well operating, and we usually screen. If they have symptoms, of course, we go directly on X-rays, etc. But otherwise, we work with Ibrahim, test, and the possibly Ibrahim patient go on for further testing. And we test people from high incidence country, not all TB care and treatment, of course, is free of charge, as for all communicable diseases. It's the same for people living in the country and migrants coming in. And we have had for many, many years a very active contact tracing run by the local communities, and that includes also migrants today. Of course, it is a bit more complicated to do contact tracing with migrants because a lot of patients have their contacts long before they arrive. But we see of course also benefits from improvement of all the relatives, trying to trace the relatives living in other parts of Sweden where people they have been contact. Are there problems? Yes, of course there are problems. So we have a major load of tuberculosis coming in every year. On the other hand, it very much reflects the influx of migrants. We don't see a big spillover on the domestic population. As you can see the graphs there, we've seen a continuous decline of tuberculosis incidence in the country, despite high influx over the last 10, 15 years. So we think it's a problem that's by and large manageable if we put a lot of effort and try to do early detection, contact tracing and treatment. We also offer prophylactic treatment relating to TB, young people and vulnerable people in the system. The problem we can envisage is really that TB is so uncommon, so it's the health sector will miss cases, especially people, Swedish-born people that come with symptoms of tuberculosis could be missed in the system. But by and large, we think we can handle this. We think that the curves will slow down and go down again when the beginning curve is over. And we also, and talking in favour of that is that most of the cases are discovered within a few years after arrival. So we don't see a lot of tuberculosis cases in the migrant population in people having been in the country for many years. So we are hopefully we are able to trace and treat most of it in a few years. Thank you.
Thank you very much, Mr. Coulter. So, anybody with experience of TB control knows that surveillance and a good functioning surveillance system is critical to TB control. We cannot function and we cannot move in an agile way to recognize the risk factors for TB and change our control program if you don't have a viable surveillance system. This is even more critical as you reach very low levels of incidence. Yesterday, a colleague was giving me an example of the Japanese system where through individual level surveillance, they are able to recognize that the highest risk groups are moving increasingly from those vulnerable groups, homeless individuals in particular cities, to foreign students. They wouldn't know that if they don't have a robust surveillance system. In Europe, we are lucky to have a center with responsibility for bringing together surveillance as well as advice on TB control across the European region. The European Centre for Disease Control that works closely with the WHO Regional Office for Europe to run an effective individual case-based surveillance system almost for an entire continent. So it gives me great pleasure to ask Dr. Ibrahim, the Director of the European Centre for Disease Control and Disease Prevention and Control, to share with us the experience of the role of cross-country surveillance and information sharing in the context of TB elimination efforts. Tell us the challenges and the opportunities. Thank you.
Yeah, thank you for the introduction and also for the opportunity to speak of one of our core business. Indeed, eliminating the very last cases of any disease, and TB is no exception here, is challenging. And not only to keep the political commitment of high. But also we need to refine and retune our methods that we have in order to make it possible for all these outreach activities that you have heard to know where to address them, to know where to find those cases and what their situation is. Now, supranational surveillance and data sharing are very crucial for that. As Ibrahim has said, since 2008, ECDC and WHO Regional Office for Europe, we do jointly surveillance for the whole European region for tuberculosis. And we analyze those data and publish the reports every day at World TB Day for maximum attention. These data are then shared, of course, with all the countries, not only with the report, but we also have on our website a surveillance atlas where countries can actually do maps and comparison with other countries themselves. And my experience is that this benchmarking among the countries is an incentive that you should not underestimate. Nobody wants to be the last and the lowest. So, but in order of this to work, it is also important to have a good dialogue, really a good collaboration with everybody who is involved. And that is important because the surveillance systems where this data come from are quite diverse. So that has an impact on the quality and the completeness of the data that we have. As Ibrahim said, we collect case-based data in order to really also be able to analyze really in a detailed way what we collect. Now, over the years, through this dialogue and really the efforts that the countries have done, the quality and the completeness of the data have improved. The case-based data collection is also very important to have, especially in this last phase, the flexibility that you need. For instance, when monitoring drug resistance, if there are new drugs that are coming up, so you can easily add them. We have also a working group where we collect or discuss whether there are risk factors, additional risk factors that we have to put in, or social determinants that might be more important for the groups that are now left most vulnerable. The in-depth analysis of these case-based data allows us also really to target specific groups. For instance, drug resistance in children, not only in general, but specifically in children, or TB, HIV co-infection. So what we, however, see as a big issue is the timeliness of the data. When we publish a report in year N, it's the data from year N-2. And that is something that we need to improve, and we have to look into this. I personally see that what's going on right now with the digitalization in the health sector, especially all the efforts for e-health, the electronic health records, have a great potential in enhancing the timeliness. And in this context, I also would like to emphasize the opportunities that whole genome sequencing provides for tuberculosis elimination. So we are now piloting a whole genome sequencing project for tuberculosis surveillance to enable the identification of cross-border clusters. And recently we have investigated a cluster of MDR-TB and XDR-TB with whole genome sequencing. And whole genome sequencing also allows to look at and identify where transmission is still ongoing. And in a recent publication in Lancet Respiratory Medicine, we and Ibrahim, we were also part of the group, and other experts propose an interim target that can be used next to the Sustainable Development Goals as a target for TB, and that can be measured by whole genome sequencing. And the proposal is to aim for zero TB transmission. That means that there's not more than one locally acquired case per million population. That's only possible if you have whole genome sequencing. So in the context of TB elimination, we need to refine our methods, and so it's essential to have TCR-based surveillance, and it should be supported by whole genome sequencing. But supranational surveillance and information sharing is really necessary, and that can only be achieved through collaboration and dedicated involvement of all partners, both at national and international level. Thank you.
Thank you very much, Andrea, for highlighting these challenges and the innovation that inevitably we will have to adopt if we are to eliminate TB. Okay, so moving on to the last chunk of introductory remarks from our esteemed panel. I alluded to at the beginning that the world is interconnected and that migration is one of the inevitable certainties of mankind. Man has always done this since man moved out of Africa, and I suspect that it will continue to happen. Politics, borders, countries may restrict that temporarily, but migration will be with us for a long time to come. This inevitably means that if we want to contain TB, in addition to all the excellent effort we've had in the individual countries, we have to deal with TB globally. So low-incidence countries have an obligation, almost as articulated in the now getting dated paper in the New England Journal about a light and self-interest. It is a light and self-interest to intervene in high-burden countries. So I'd like to ask, in relation to offering expertise, transferring research capacity, as well as providing support through cooperation mechanisms, whether Dr. Stephanie Williams, the Principal Sector Specialist for Health at DFAT Australia, can tell us about the Australian contribution to regional and global TB response. Over to you, Stephanie.
Thanks for the introduction and the opportunity to speak. So Australia is committed to reducing the burden of TB globally as well as in our region, and we do that through offering support in the global programming sense, investing bilaterally in health systems, and leading regional work like health security. And I offer the perspective today for the Department of Foreign Affairs and Trade, which many of you know since 2013 includes the Australian Aid Agency and the Australian Aid Program. So from a global perspective, in September last year, Australia pledged $220 million to the fifth replenishment of the Global Fund between 2017 and 2019, and that represented a 10% increase from our previous pledge. And our investments, amongst several others in the Global Fund, have helped treat over 8 million people in the Indo-Pacific region, at least with TB. In addition to supporting this global action, Australia's aid program has bilateral investments in the Pacific, particularly focused on improving TB detection and treatment. And two standout examples includes in Papua New Guinea since 2011 to 2017, $60 million on a comprehensive support package to improve TB control, support for health workforce, infrastructure, community treatment, laboratory services, and technical expertise. And in Kiribati, $4.8 billion for the construction and equipping of a TB control centre and laboratory. So the majority of our bilateral investment is indeed focused in the Pacific region. And the Indo-Pacific region, which is the Australian framing of the region, largely combines with Wipro and Sierra. When we look at those two, it's almost 2/3 of the global burden of tuberculosis in terms of new cases, almost half the deaths, and almost half of the drug resistance. But in that sense as well, when you take a regional view, Australia is increasingly directing energy into building strong national health systems in the region with the capacity to detect, prevent, and respond to all manner of infectious disease threats. And we have a new Indo-Pacific Health Security Initiative with a particular focus on the problem of drug-resistant TB. And under this initiative, this initiative was launched in October, it's only about a month ago actually, by Julie Fisher. And it has allocated $300 million to contribute to the avoidance and containment of infectious disease threats with the potential to cause social and economic harm on national, regional and global scales. And the initiative will work across the full spectrum of prevention, detection and response to look at disease surveillance systems, improving health workforce, enabling countries to tap into more effective and new treatments and diagnostics, as we've heard a lot about today, especially in the previous research section, and supporting coordination amongst partners. And this initiative, to demonstrate political commitment, is led by the Ambassador for Regional Health Security, Mr. Blair Excel, is one of only a handful of thematic ambassadors from the Australian government, and it is administered by the Australia-based but called Indo-Pacific Centre for Health Security. Under this initiative, the single largest investment to date has been a $75 million contribution or funding of product development partnerships. There's currently an open call out for PDPs with a focus on malaria, TB and vector control, and that builds on Australia's previous 5 years of investment in these important mechanisms for bringing new drugs, diagnostics through the pipeline to market. And Australia's investments in these PDPs and support in Papua New Guinea enabled the rollout and successful pilot of the first child-friendly dose for TB medicine not long ago. So that's just a very practical snapshot of the way Australia frames its response from a global, regional and bilateral view. And we certainly a committed partner in the goals towards TB elimination.
Thank you very much, Stephanie. So, last but by no means the least, the United States of America. The US has been a leader in TB elimination for decades before the rest of the world woke up to the idea of TB elimination in its domestic program. Complementing this incredible domestic effort is a massive global program supporting the operations in many, many countries, but also in R&D. So it gives me great pleasure to carry on the same conversation to ask the Chief of Global Tuberculosis Branch of the US CDC, Dr. Søren, to tell us about how you work with ministries of health and other partners to support the global TB prevention, care and treatment effort.
Thank you so much for that introduction, and it's really a pleasure and privilege to be here, and I want to thank the WHO and the conference organizers for the invitation to participate in the panel. I'll just start by saying the U.S. government and the global community share a vision for a world without TB, and to reach that vision, we are committed to working alongside our partners around the world to reach each person with TB, to cure those in need of treatment, and to prevent the spread of disease and new infections. And really eliminating all forms of TB would have widespread health, economic, and social benefits for the U.S. and for the world. I'm here representing the CDC, but really the larger USG effort, so I wanted to start with just giving you an overview, if I can, of the different agencies involved in the U.S. government's global TB efforts. So the first that I'll speak about is USAID. USAID is the lead agency for global TB efforts, supporting TB programs and systems in the countries most affected by TB, and they also assure coordination for all the other USG agencies that work in global TB. The second agency I want to mention is the National Institutes of Health, or the NIH, and they are the lead for USG TB biomedical research. They conduct and support research and project development both domestically and internationally. We have OGAC, which is the Office of the Global AIDS Coordinator, which is the lead and the coordinator for U.S. efforts around TB, HIV. And we also have the Department of Defense, which does work in supporting and monitoring in some countries the quality of TB diagnostic services. So now we have CDC, and we work alongside with these USG agencies, and we really strive to maximize the impact of the U.S. government's global TB efforts by developing the evidence base, if you will, from proven and innovative approaches to find, cure, prevent TB. And we like to help translate this information into guidance and policies, and then finally to help scale up these approaches through technical support and assistance with program implementation. I will say that CDC is also a major implementer of PEPFAR, and that is the President's initiative, the President's emergency plan for AIDS research, which is coordinated under OGAC. So we work as well in TB, HIV. And lastly, as was already mentioned, CDC is also responsible for domestic TB control and elimination efforts. So with that overview, I'll talk a little bit more about CDC's unique role. We work and have offices in more than 50 countries around the globe, partnering with local governments to evaluate and strengthen health systems and fight diseases. For TB, we have offices in some of the world's highest burden countries, where we're aiming to work with ministries of health to understand what's driving the spread of TB and to stop it. CDC has a very strong scientific and technical expertise And we try to leverage that as well as our peer-to-peer relationships with ministries of health to support national and more local TB programs as they scale up innovative approaches to find, cure, and prevent all forms of TB, and also as they address technical and operational challenges, if you will, that can really undermine progress towards achieving global and national TB targets. We also bring technical know-how and a track record in building TB and HIV programs, and our expertise in helping to strengthen science and laboratory networks. We also assist the Ministry of Health and national TB programs in the strategic use of data to increase the impact and effectiveness of their programs. So that's an overarching look at CDC. Our mission and strategy is focused on efforts, as I've said it a couple times, find, cure, and prevent TB, HIV-associated TB, MDR-TB in both adults and children. And I just thought I'd go through each of these elements and just give you a few examples of the kind of work we're doing in partnership with ministries of health. So in the find area, we're looking to help expand access to better screening, contact tracing, and diagnostic tools to find missing cases. And we actually have contributed recently in a partnership to develop a new algorithm to improve TB diagnostics and treatment in children. And now this is forming national guidelines for pediatric TB policies and programs. We're also working on a regional and a national level with the World Bank to develop innovative mobile and cross-border service delivery models to improve screening and diagnosis of TB among minors in Southern Africa. In the cure category, in evaluating better treatment regimens and expanding access to treatment, we are working with the government, CDC is working with the government of India, focused on reducing MDR-TB in Mumbai, by strengthening efforts to find missing cases, especially in the private sector, by building laboratory capacity in both the private and the public sector, helping people stay on treatment, and strengthening the infection control measures in the city's health facilities. On the prevent side of breaking the cycle of transmission, we strive to strengthen infection control, identify TB hotspots, to intensify screening efforts and scale up treatment to prevent TB among vulnerable populations. And in this realm, CDC has a new initiative, if you will. We're leveraging our PEPFAR platforms to really scale up preventive treatment for HIV-infected people living with HIV, as well as children. And then on the enhanced side, in terms of developing surveillance systems, enhancing laboratory and diagnostic capacity, CDC really has developed a robust laboratory quality improvement and accreditation mentoring system that is called SHLIMTA, if anyone's heard of it. It's the Strengthening Laboratory Management towards Accreditation, and is really helping to build some strong laboratory networks across Africa and Asia. So in closing, I'm going to just echo what our chair has said before, that TB continues to defy borders, and we're not likely to eliminate TB in the U.S. or any country without intensified focus on controlling TB globally. And in fact, research has shown that strengthening TB control programs abroad, coupled with overseas screening, has a greater return on investment than just overseas screening and trying to treat populations in our country. And so, in this age of making the investment case, I would say that besides it being the right thing to do, we can certainly say that there are domestic returns on investment for investing in TB control in other countries. And we're committed to it. Thank you.
So thank you very much, Susan. We have another 20 minutes for discussion, and I'm going to combine asking our esteemed panel for more input on specific issues, and I can see three generic themes emerging: political will and commitment, high-risk groups including migrants and the need to have better surveillance, and the international effort to make sure that we contribute to global TB control with the efforts and experience of low-incidence countries. And then I will try to draw in questions from the audience, hopefully keeping the responses brief so that as many people as possible have a chance to contribute to this discussion. I'll kick off with going back to where we started about political commitment, and ask the honourable ministers for some insight into TB, because it affects vulnerable groups and a limited section of the population, would benefit from linking into other important priorities. So making the investment case, to saying this is good return on investment, global health security, saying most countries recognize that global health security is important, antimicrobial resistance, and the fact that countries are signing up to compacts on migration through the UN. All of these agendas are happening in parallel, and at the government level, with your other ministerial colleagues at the policy level, there are specific opportunities to link the TB agenda with those. And I'd be interested in your view, Honourable Minister, as to how we can maximize that and how we can support you as an expert community.
Thank you very much. Generally, you give a question together with an answer.
That helps.
Yeah. So, if we speak about marginalized groups, so specifically in case of Slovakia, we're speaking about Roma communities. It's roughly 500,000 live in the east part of Slovakia, mainly in small communities, but with very bad health conditions. And it's I would say it's an issue which didn't come through a few years. It's something which we have for decades, and we have really challenges how to integrate those people to the major community, because it's not the case that the majority wouldn't like to accept them. Often those people don't want to live the way of their lives. They are undereducated, and what we did is that we try to help them through their own communities. So we were able to find appropriate people, assist them directly from those communities, from those villages, educating them, and they are helping with young people, with small kids, with people who sometimes don't recognize what is the toilet. So helping them with basic hygienic habits and so on. So this is something what is really incredible in today's world, in Europe, but it's something what really works. And what is the government doing? It's definitely supporting any programs for this community, basically investing in the education, in the social environment. Of course, that I think that coming to your question, that we need to have experts who really understand disease management, especially if we are speaking about TB Slovakia, former Czechoslovakia, has very strong expertise. We have the centers, we have very close collaboration with WHO regional office, and but it's definitely not about TB. When we discuss it, the TB strongly related with other infection diseases. If we look to Ukraine, we see many people suffering from TB together with HIV, hepatitis C, and so on. So everything is somehow related to each other. So we cannot focus only on one disease. We need to really understand the causes, why it's happened, how to tackle on these issues and being. So I heard my colleagues. There are many different approaches: centralized, decentralized, public coverage, universal health insurance system, which also we have in Slovakia, but there are other systems which also work quite good in the United States or something. So it's really about the ambition, about the effort, and be systematic. So it's necessary to collaborate between government and experts, doctors, communities, and so on.
Thank you very much for that. So sticking to the subject of high-risk groups and vulnerable groups, I'd like to ask a question to our Northern European and Canadian panel members around this issue of, as the incidence of the disease declines, interventions become more difficult to show as cost-effective. And where you are challenged by the wider system to demonstrate things are cost-effective, and if we are really serious about elimination, as is happening with the global polio eradication effort, you may have to do things that governments do not accept are cost-effective. How do we go about tackling that, and how are you doing in your individual countries to say screening this migrant group is important because it is important, not because it's simply cost-effective per pound, per dollar?
I think that is very much to the point. I agree very much with Minister Drucker that if we have to achieve sustained elimination, we have to focus on the inequities in health, education, integration of vulnerable groups, etc. I think another reflection from listening to all the presentations here that we have very similar situation in our countries, and we all represent countries, Cuba, Denmark, Canada, etc., all represent countries with a very high degree of universal health coverage. But even despite that, we have challenges. So the lesson learned is certainly you need to have strong universal health coverage to be a low incidence. But for elimination, you need something extra that is not simply achieved with having, like we do, a very high quality, specialized and centralized healthcare service. So we need to look at more structural solutions for these vulnerable high-risk groups. And we need to look at what works. And that's why I was highlighting the example of Sweden, because we are certainly looking to that. Speaking about the situation in Greenland, which I said has a very high incidence rate, what is really disappointing is that 25, 30 years ago, we had a much, much lower incidence rate in Greenland. In the 1980s, it was approaching low incident rates in Greenland. So in the 25, 30 years, not much has changed in the social compact of Greenland. So it's really a structural thing of losing focus on contact tracing, etc., early detection, etc. So that's where we should look. I think the challenge in raising political awareness is that advocacy is not very strong for these groups of homelessness, immigrants, substance abuse, and there's not a very strong advocacy regarding TB, even compared to HIV and hepatitis and other diseases. So I think the lack of strong advocacy groups puts an extra strong obligation on us as policymakers, government representatives, global community and WHO, etc., to focus on these groups. And that's where we have to show the good business case. I think we can show the good business case, Ibrahim, and also show that it will be cost effective, and also show that it's necessary to eliminate.
So the Honourable Minister will respond, and then
just one point I wanted to underline, and it's very important because when I listen to my colleagues, it's important that if we want to really be successful, we cannot close eyes on our problems. We have to be able to say we have also issues, we have challenges. So you mentioned surveillance, control, and we need to really be honest to ourselves that there are some still challenges. We need to really know the real facts, figures, numbers about new cases and so on, because once we just don't want to see it, then we cannot be successful in achievement of close to eliminate diseases such as TB or the other ones.
thank you.
I just have 2 points to make. First of all, I think in Canada we're fortunate. We have a very unique opportunity that we have a political commitment and we'll at the highest level, so as I said before, related to our relationship with our Indigenous peoples. And so with that commitment, our government and our Prime Minister has actually taken a large step in terms of our recent reorganization with departments. We recently announced, this was about a month or so ago, a new Department of Indigenous Services, which combines everything from healthcare to other aspects such as housing, etc., to actually improve the state for our Indigenous peoples. And so, using that as a leverage point, recognizing there's a whole host of conditions that indigenous peoples suffer from disproportionately, including mental health and chronic conditions. We're also adding TB to that list and saying that we have to have a holistic approach. It's not just a biomedical approach in terms of drugs and treatment and so on, but we have to improve the social living conditions, the housing and so on. And there are political masters who understand and get it. And I think that's really encouraging for those who are, quote, the experts in the field, recognizing that we're not going to just tackle TB head on, but we're going to tackle HIV as well as a co-infection, as well as chronic conditions. And so we're using that as sort of a starting point. And I think our political leaders recognize that it's not all about cost. Sometimes it's just about doing the right thing.
Thank you for that. So I'd like to open up for questions to the audience. And I'd like to start with the subject of migration. We only have 5 or 6 minutes, so they have to be brief questions and responses. And I want to get an idea of 1, 2, 3. I don't think we fit more than 3. But I would like to start with the question of migration. I'm currently leading a commission for the journal The Lancet on Migration and Health. And one of the things we've come up with is looking for countries with excellent examples of models for taking care of migrants and their health. And Switzerland stands out. So we're delighted to have in the audience Ambassador Crowley, who might be able to comment on the Swiss system and what they are doing and what we can learn in TB. This microphone.
Merci beaucoup, merci aussi pour le partage d'expérience. Je trouve qu'on a effectivement tous des situations similaires. J'aimerais faire 2 points ou 2 remarques sur ce qui a été dit. En Suisse, on a une baisse de cas et dans la population née en Suisse et dans la population qui a migré en Suisse. En revanche, on a une augmentation des cas en réfugiés. Donc, dans notre approche, les 2 éléments qui me semblent les plus importants et qui peut-être peuvent contribuer à la discussion, c'est premièrement, justement, pas entrer dans une stigmatisation de ces populations, parce qu'on se rend compte qu'il n'y a absolument pas d'influence de tendance négative ni sur la population née en Suisse, ni sur la population qui a migré de cette augmentation des réfugiés. Et la deuxième chose qu'on a faite, c'est en fait se départir d'un modèle général avec une seule solution pour tout le monde, mais d'essayer vraiment de tenir compte aussi dans notre stratégie de l'utilisation la plus optimale des ressources. Donc en 2006, à titre d'exemple, on a arrêté le screening généralisé des réfugiés qui arrivaient en Suisse pour une solution beaucoup plus concentrée sur les réfugiés en tant que tels, en mettant en place en fait un questionnaire de tuberculose disponible en 30 jours pour sensibiliser les réfugiés, en l'amenant ensuite dans un deuxième temps à faire le nécessaire. C'est-à-dire qu'on a plus de 4% des réfugiés qui ont suivi un screening radiologique. Et je pense que ce genre de réponse combinée tenant compte aussi des limites de ressources qu'on a en la matière ont été vraiment une expérience positive pour nous. Merci.
Thank you. Yes, there's a response from the panel.
Yes, thank you. If I understood correctly, I think we are sort of embarking on the same road as the Swiss system. We are not doing one size fits all any longer. We're trying to focus on more on technical tuberculosis rather than saying this is something everybody should undergo testing for. And also when it comes to priorities, I mean, for us it's not very much a matter of funding. I mean, we have the case are still in the lower range. I mean, it's more of a political commitment to solve this problem, to avoid stigmatizations, to avoid that this is a part of the debate on migration. If the migrants are coming with diseases, and if you don't analyze the figures correctly, you get the impression that the situation in Switzerland are deteriorating because we have many more cases. But as we see, this is not the case. We are solving, or we are trying to solve that problem, and I think it's very important to be technically correct and scientifically correct when you describe the situation, but of course it's used in the debate differently. So focusing, avoiding stigma, doing the right things rather than money. For us, it's not an economic problem.
Howard, we started about 5 minutes late, so I would urge your indulgence for us to carry on for a little bit longer. I'm usually obsessed with timekeeping, but I want to let this go on for a little bit longer and delay your lunch if it's all right. Howard?
Je vous remercie pour votre intervention. In Canada, the way we look at it is that we look at our foreign-born cases. 70%, are foreign-born. And we analyze and we find out that most of those cases actually occur within the first 5 years of arrival to Canada. So we're finding that the active cases at screening before they come, and we treat them, make sure they're treated before they come. But something happens for those who are not caught by chest x-ray, who have actually have latent TB infection. So we take to heart that somewhere along the migration pathway, we should do better. And we take, I guess, the theory, the hypothesis that physiologically, immigration is one of the most stressful life events. You know, finding a job, a school for your children, getting used to our northern climate, etc. So we think that's why a lot of immigrants might be breaking down and developing active TB. And so we're looking at more proactively, maybe testing for in a non-stigmatizing way, and offering treatment. And I think because of a universal healthcare system, people are accepting it and not seeing that it's a problem. So our challenge now is working with our provinces and territories and looking where's the ideal spot to do this. Is it prior to arrival as part of the immigration medical exam? Or is it maybe best done at sort of the final point of destination in the province and territory where you settle? I think the question's not there answered yet. It's still in some ways a bit of a research or a programmatic issue. We need to do further exploration and hopefully implementation and evaluation. But that's where we're heading in Canada in terms of the migrant aspect.
Thank you for that. Daniel, Thank
you very much. Yeah, Daniel from Jerusalem. Yes, indeed, we have very similar issues. In Israel, we have 90%, 90, who are foreign-born among TB. And however, I think we have many things in common. I would like to emphasize a few points. First point, it's definitely the issue of pre-screening. After screening is an issue, because as you said very correctly, the pre-screening is just picking few people, and you should be, as a country, be able to allow after that a full access and free of charge access. And not only for TB, also for HIV. That's what we did in Israel. When we have many migrants from South Africa, you need to also offer TB treatment and HIV treatment. Even the guy is undocumented. And this is the second issue. We have very good level of adherence if the person knows that it will not have any impact on his stay in the country. So, of course, we need to prevent stigmatization, but also we need to prevent any kind of deportations, something like that. The last issue, I wanted to say that, yes, it's important to collaborate with the country because we have the same things, and at the end of the day, if we want to go to elimination, so definitely we will not be cost-effective sometime, but we still have to keep in place our structures.
Thank you for that, Daniel. One last intervention from IOM, right at the end of the room.
Thank you very much. My name is Jacques Nuekas. I'm representing the International Organization for Migration. I have 2 points. One is, so labor migrants, they are part of all countries' workforce today. And in that respect, I really applaud the interventions of the panelists that show it is possible to provide adequate access to diagnostic and treatment for migrant populations. Not to forget that many millions of labor migrants in the world today, however, upon arrival in a destination country, undergo health screening, TB screening, and are deported in case of abnormal findings without further referral. So this is not the way to go in terms of public health, human rights, and it does only increase irregular migration flows with further complications. Second point, the global compact on migration. I hope you are all completely up to speed on this. If not, do pay attention to this. The Global Compact on Migration is a member state-driven process. So you are, the member states, you are going to be putting this together and you are designing the near future migration management architecture in the world. The bad news is the Global Compact on Migration had already 6 thematic sessions. None of the thematic areas of this process addresses health. Health does not appear. Together with WHO, Ireland has been working hard on trying to mainstream migrant health into the compact, but again, it's a member state-driven process. The second phase of this process is going to start now. It's called the stock-taking process. That means that the Secretary General is soon going to receive a zero draft of this global compact, which is going to be finalized in 2018. The stock-taking conference is going to take place in Vallarta, Mexico, in the first week of 8 December, I think. It will very much depend on the member states to what extent health will be integrated in this compact. So really, really hope that you will talk to your counterparts in your governments and ensure that health will be addressed in the Global Compact of Migration. If not, then this will be a big steps back a lot. Thank you very much.
Thank you for that. One last one, and then I'll round off the session. Yes, is that it?
So, Dick Menzies from Canada. Just a somewhat independent, perhaps, perspective. So, a couple of questions for the panel. First is the migrant screening that everyone's talking about really directed to public health benefit? Because I would submit that there is little or no evidence that there is public health impact, either of the migrant TB on TB in the general population, other than perhaps to their own families. And so it is perhaps mostly an individual benefit, and if viewed from that perspective, you know, why not all the other health problems that they have? And the second question is whether anybody on the panel here believes that they can eliminate TB in their own country, either by eliminating migration or by eliminating TB in the rest of the world, following what Susan Maloney was talking about.
Thank you for those questions, and we'll use them to end the session. I'd like to go to my Swedish counterpart to give the first response. Yes.
I'll refrain from response to the second part of the question, but when it comes to health examination, I think we realize that this is for the benefit of the individual rather. I mean, we try to put in place something that attracts people, they come forward. We talk about non-communicable diseases, including diseases, as an extra benefit. Yes, it helps us also to control, to trace tuberculosis if it's done properly. But it's not mainly a public health measure. No.
So should we go to Søren and then I'll...
Yeah, I won't comment on the migration differences in migration politics across countries. I will just note or observe that the governments of Denmark and governments of Sweden have had very different migration politics. And so my country has had a very restrictive migration, whereas they have had a much more liberal and open policy in Sweden. And despite that, we have bigger challenges in Denmark regarding TB. So as a real-life experiment, that certainly underscores that you will not eliminate TB active transmission by eliminating migration, I think.
Thank you. 2 points. I guess the first question I would say, that, no, I think primarily it's for the individual, and certainly I think the intention and philosophy for our migration medical screening is to basically give the applicant more information about their health, so then they can access the proper health services that they need. So by screening for TB, but also for HIV, it's not for exclusion. For HIV, in this case, many people may be unaware of their status, and then by knowing their status, they can avail themselves once they land in Canada of the right services. With respect to your second question, certainly I can't speak for immigration policy, but I think collectively we're all I think committed to TB elimination around the world. And certainly in Canada, we always have had an open migration policy. We welcome people from around the world. Most recently, Syrian refugees, our Prime Minister was personally welcoming some of them. So I think in Canada, it's really not an issue. We deal with whoever comes to Canada, with whatever health conditions they may have, ensure that they become healthy and become productive members of Canadian society.
Thank you very much for that. Sadly, because it's lunchtime, I will have to round up this session. Thank you very much to our eminent panel for your excellent contributions. I think we've covered the subjects of political commitment, risk groups, and the international TB control effort and contributions of low-incidence countries. I think the last question has also illustrated to us the importance of the migration issue and why we must all sign on to the intervention that Ibrahim just highlighted. I'm really, really grateful that you are here. There are many more topics we could have discussed, but I think we've covered the really important ones. Thank you.